She said the esophagus. I don't have a picture of that, but the esophagus usually runs posterior to the left atria. So let's say the esophagus runs here. You're in good shape. Usually, this is a little rotated. Usually,
It's not the scale.
yes. Yeah. Let's redraw that. So let's say the esophagus runs like this in this case. You are lucky. You can do your burns and everything is fine. Risk of damaging the esophagus is low. But usually you're not that lucky and it either runs like this or it runs like that. So there's different techniques to try to see where the esophagus is to lower the risk of a complication that happens when you burn the esophagus. Anybody knows what the complication of burning the esophagus is called? What does it cause? Yes, I was hoping nobody will know it, but someone knows it. Have you seen atrio-esophageal fistula? That's the name. What happens is you have the esophagus running like this, and right next to it, you have the left atria, and you have the left ventricle, and you burn here, and you cause a fistula. Fistula basically is a communication between two cavities. So if you have the atria there and the esophagus here, this is the esophagus, this is the left atria, and now you have a fistula. What happens? Any takers?
Food is in your heart.
Blood goes
Or
in your... I'm going with stuff that movies are made
Bad
out
stuff.
Yeah, you have both. You have both, and that usually ends up really bad. Really, really bad. I so far I knock on wood. Yeah. There. I knock on wood. I have not had this problem. It's very rare. The incidence is one in the several hundred, several thousands. So, since it's so infrequent, we don't really know how to prevent this. A lot of us use a temperature probe. So let's imagine the esophagus is here. So we put a temperature probe with a thermometer here. And we move the thermometer as close as possible to our ablation. That way, if the thermometer shows that it's warming up, well, stop. Right? You don't want to warm up the esophagus. Now, some papers, some data suggest that the esophagus acts as the probe can act as a grounding electrode to attract those frequencies, and it will warm up the esophagus more. So, what's better, to have a probe or to not have the probe? We don't know. Some other people say if you have a probe, you're missing all the other area of the esophagus. The esophagus is never a straight line like I just drew it. The esophagus has turns, and it has pouches like that. So if I see the temperature probe here, I'm like, oh, perfect, I'm just going to burn all over here. And then you burn right in the esophagus. So at some other places, what they do is they ask the patient to swallow barium, that you can see it on x-rays. The what?
Because they do a swallow study.
Yeah, exactly.
Yeah.
A swallow study. And then you have the contrast sitting there, and you can do the ablation. But then there's a risk of aspiration. And also, to complicate more things, is we don't know if the esophageal fistula happens because you just burn the esophagus or because you burn the arteries that bring blood to the esophagus. Because these fistulas happen weeks after the burn. So why would this happen a month after the burn? Well, because These are all theories, right? This is so rare that we don't know. So if you burn the arteries that bring blood to the esophagus is going to die, and then it's going to create a scar, and then it's going to break. So what are the things that you got to watch? When you have a patient that had a history of ablation more than a couple of days ago, and he comes in with fever, be worried. It's usually not it's usually UTI, it's usually pneumonia, pericarditis, it's usually something benign. But the number one thing that we all miss is the fever. That is how it presents a lot of the times before the stroke. So stroke is already a little too late, but fever is first. So if you have a patient that had an AFib ablation and present with fever, don't worry, don't be, you could never be too paranoid. Just in case, order a CAT scan. Never order an EGD. If you call GI and say like, can you put a probe there to see what's going on? No, because it could be that it's a tiny hole until you put a big probe in it, and now it's a big one. The mortality of this is about half, 50% of patients die despite surgery, and the other ones end up, some of them end up doing okay, but a lot of them unfortunately have a big complication from neurological, from the air. The air that goes, it's not food because patients are not really eating at this point in time. It's usually air that goes into the left atria, and from the left atria goes to the brain. So very, very careful when a patient has that complication.
Can we seal that with the same thing that you do with the TFO? The little patch? Could they do something similar to that?
That's a good question. No. The long answer is the short answer is no. A lot of reasons why no.
I've seen. Well, they were doing a biopsy through the esophagus to a node, lymph node, and they accidentally poked the heart with the needle. Does that?
You want that? No, I just wonder if I'm taking your.
Does that still have the same problem?
Oh yeah. I'll get that. Now, if one thing is a poke, another one is a curve. Is a fistula. Yeah. So I never heard of anyone doing it. Usually it's surgery. You need to open up right away and separate the two structures and stop it. Doing an amplatz or something like that, it's just no. No one have done it, and I don't think that's a good idea. It's just way too complex. All right, so I don't know how we got distracted with this, but oh yeah, that's right. We're talking about structures next to it. So whenever we burn, we have to think about all these things. It's not like how aggressive are you? That's how we got to this.
Sorry.
So yeah, we are aggressive, but we try not to be too aggressive. A little too aggressive is too much. The other structures that are around there are the bronchus, the lungs, and all the structures with the lungs. There's the phrenic nerve that you got to be very careful as well. And although there's some reports about causing acute MI from burning the arteries, but those are rare. They're quite rare. I actually took care of a patient who had an acute MI from burning there, but it is quite rare. Yeah, I was in training. So all right, so that's about that. Now